Mike Kendrick. Mike is going to discuss his experience, put it into perspective using these grading scales, and give us an idea of how your perspective has developed and evolved from Rochester. Thank you.
Thank you. Well, it's my pleasure to be able to play a role in talking about this. What I was also charged with is talking a little bit about the learning curve. And so I'm going to talk a little bit about where we've been along the road, not so much about the details. I'm not going to show one single video, so if you were counting on that, seeing it for the 12th time, you're not going to see it a 13th time today. The slides coming up?
Should have used your Mac.
I should have. I can still get it.
What is it, your title called? I have 30.
Learning curve?
Learning curve?
Changing outcomes with learning curve.
Okay. Okay.
Thanks, Tim. Can you also start the timer when Dr. Kendrick starts to speak? I took all your time.
So the real question is, can we make improvements? Can we do better than the open approach? And I think, as complex as the pancreatic oduodenectomy is, it's clearly been shown that we can do this through minimally invasive approaches. You may have seen a table like this before. This shows now the series with 30 patients or more in them, and you can see that the outcomes for either robotic or pure laparoscopic are very similar to those that are reported for open. So the operative time, I think, is generally quite a bit longer. You see the bottom 3 studies here are predominantly robotic. In our series, we had done some robotic as well, but these top studies are basically representing the total laparoscopic approach. And the outcomes are quite good. In terms of blood loss, the fistula rates are a little higher than I think we would like to see them, the delayed gastric emptying, length of stay, and mortality. These clearly represent a learning curve, and I think we need to be careful about that. As we scrutinize these, which I think is very important, it's also important that we remember that things are going to take some time. We're not going to be able to equal or better necessarily every outcome that's been reported by masters of surgery doing it open, but the hope would be that we could see some benefits, and hopefully I'll be able to show you that. Well, since our publication in 2010, we're now at just over 200 laparoscopic Whipples. And surprisingly, if you look at this table, the operative time, the operative time is not a whole lot different. The blood loss is not a whole lot different. The fistula rate's not a whole lot different. I think what this means is I'm a slow learner because it just hasn't really changed. What has changed, though, is the way we do a lot of things. And I think there's answers for some of these rates, and we'll talk a little bit about that. If we look at just the operative time, you can see a nice gentle drift here in operative time. This is grouped, the 200 patients grouped, 50 patients each group, so not by time but by number of patients that we did. And you can see there's a little gentle curve there, and I think that was part of the learning curve. We were getting this down. It was down less than 6 hours pretty routinely. But then it was right around that point that we decided we could do more. And so that's when we started to do the portal vein resections laparoscopic, started to take on other bigger cases, neoadjuvant treatment with radiation, maybe combined procedures. And so I think that's probably why it went back up. But you can see in the last 50, the time's gone up a little bit. Overall, the time is right around 6 hours as an average. What about for blood loss? Well, blood loss, I think, has always been fairly good in most of the laparoscopic studies, and it's no different here. It really hovers around 250 with an average for our, or a median for our series of 200 at 250 cc's, which is actually on the low end of most reports of open, even the largest and best studies. The fistula grade, I think, has been probably the most discouraging part. The first 50, when it was 20, we thought it was going to plummet because we finally figured it out. I thought we were learning. The next 50, it was 20. The next 50, it was 20. And this last 50, it's been a little bit lower, but I'm not sure that I've changed a whole lot. And I think there's several reasons for this. I don't like it at 20, but again, we need to be transparent. That's what it is. A couple factors. One is there may be some patient selection in here. We're trying to work on that. We're actually, with the 200 patients that we've just hit recently, we're doing a comparison to all the open so that we can give some good data in terms of how comparable these are to our general practice of the procedures that are done open. One other thing that I don't do is I don't leave drains, and I think these are B and C grade leaks, and I think that although the patients I don't feel are that much more sick, if they get an antibiotic or they need a drain manipulation or a drain put in, I should say, that's automatically a B. And so I think maybe some of the A's are B's, and that may account for this, but we're going to study that. What about delayed gastric emptying? This has kind of been around, but 12% is where we're at in terms of a mean. Like Dr. Traverso, I think the last 100 or so things have decreased. I don't know why exactly, but I think that maybe just experience, some of the technique, it's a little smoother, it's a little bit more efficient. A straightforward Whipple without a vein resection is typically around 4 or 5 hours, not longer as we did in the beginning. And so I'm hoping that's to answer for some of that, but we'll see what happens. The accordion severity, this is B and C. This is, again, a little higher, and I think before we can make judgments or tout success on some of these, we need to make sure our patients are comparable. We have no idea what the risk was for that patient, what specific factors went into that. But at least the last 50, that seems to have come down, and we're at 26%, which is higher than we'd like it, but again, that's what it is. Well, how does this compare? I'm not, Horatio's going to do a comparison with open, so I've just put a couple studies on here. These are again, 5 of the laparoscopic or robotic series, along with 2 series. One is Dr. Traverso's report here just a couple years ago of 507 patients. And then this one here by K. Reed Lombardo is a consortium of the pancreatic fistula group with 16 centers, I believe, and 24 surgeons. And these were people who entered their data into the database. So this is probably the cream of the crop. I think if these 24 surgeons don't have all of those great numbers that we're shooting for, I think we all have a little bit more work to do. But if you look at those, the operative time is at or a little higher than some of the laparoscopic. The blood loss is very comparable. I think most of these are very comparable without the statistical analysis at this point. But Dr. Asman's going to talk a little bit about that, and as I said, here in the next month or so, we should have our internal comparison for some data for you. So what about this learning curve? I would love to be able to tell you that here's the learning curve and it's 102 Whipples and everybody can shoot for that. I don't think that'll ever happen. I'm not sure that I'm a big fan of learning curve, the conversation in any procedure, because I think everybody comes from a different background. We know we all learn differently. It's just amazing that we think we're going to pin down a number which is going to represent a learning curve from a chart. Part of the problem of deciding when the learning curve is either flattening or almost over is the fact that, as I mentioned, as time has gone on, when we thought times were getting lower and our outcomes were improving a little bit, that's when we moved to the next level to be able to do everything that we do laparoscopic. And so we added vein resections. We added cases where we're doing a combined total gastrectomy or a liver resection, or the patients are a little bit more complex. They've had a gastrectomy or a colectomy and neoadjuvant therapy. We've done all these, and they are more difficult and take a little bit more time. And then, as I mentioned, adding major vascular resection has clearly added some some momentum to keep the learning curve going for us. So I don't think I'm anywhere near the end of the learning curve yet. Also, as I mentioned, I think there's a lot of difference and variability in how each individual surgeon emerges from this learning curve. It really depends on where you came from. If you didn't have very much open pancreatic experience, I think your learning curve is going to be longer because you're going to be learning all the tricks and the areas of danger while you're learning a new technique with the laparoscopic or robotic approaches. Similarly, I think if you're a very experienced pancreatic surgeon, if you have no advanced laparoscopic skills, the learning curve is going to be much longer than someone who, from Japan that does 200 laparoscopic gastrectomies a year. It's just going to be different. And then I think the volume is really important, and Dr. Farnell's spoke on that before about the number of cases that are even available, and if everybody in this room was going to do laparoscopic cases and the learning curve's 200, how long is it going to take all of us to get there? Because there's just not that many Whipples to go around. And you have to have them, not just the volume. I'm convinced that some of the ways we've been able to improve what we've done, and certainly the time, is just have them regularly. Every week you're doing 1 or 2. If you do 1 a month, that's great. That's 12 a year, but it's going to take a really, really long time to be able to remember where exactly your trocars should be and the tricks that'll help it become less of a painful procedure for you. So the question, are better outcomes possible than for the open approach, is what the title of my section was. And I would say, well, there's clearly the potential. I think the minimally invasive advantages of reduced blood loss, reduced wound morbidity, which nobody really has addressed yet, which we'd like to do, because I think that, although not common when you have an open midline or a subcostal, that really affects adjuvant therapy and just quality of life for the patients. And we've seen that just dry up in our patients. I mean, it is extremely rare, even when they leak, to have a wound infection, let alone have a big open wound. Shorter hospital stay, I think, has potential advantage, quicker recovery. Quality of life, I still think we need to do more on. And then there may be oncologic advantages in terms of exposure, reduced blood loss, quicker recovery, and the effects of the operation itself. So again, are better outcomes possible than for the open approach? I would say absolutely they're possible. Will we be able to show that is another question. But I think as more and more of us do this, more data comes out, we're able to compare. As Dr. Traverso mentioned, as we're able to objectively compare across approaches and technology, I think we'll make great progress. Thank you.